KURIAN.
Good morning, everybody. My study is on craniofacial fibrous dysplasia, or CFD, a surgical conundrum. So CFD is a rare genetic disorder where normal bony tissue is replaced by fibrous connective tissue, and this occurs because of a mutation in GNA's gene, and it causes skeletal lesions, skin hyperpigmentation, and endocrinopathies. So the clinical spectrum is actually quite wide. You can have just a mild asymmetry to significant cosmetic disfigurement to, I don't know why this has come like that, to significant proptosis and dystopia causing double vision. And radiological variants can vary from the typical ground glass appearance, sclerotic type, cystic type, and pagetoid variant. We also notice two types of anatomical variants, anterior and posterior, and we notice some patients have multiple bone involvement. Some have limited disease with a single bone but can have large cystic components causing significant compression. So the best practice guidelines actually tell us to wait and watch, and this was from a consortium of 51 experts over 13 countries. There is some sort of guideline on when to use bisphosphonates, especially when you have multiple fractures on the involved bone, severe pain, or elevated serum bone markers. Surgery is always advised with caution only if there is significant compression causing optic neuropathy and vision loss. So by the sound of it, the guidelines are actually quite gray, and we just wanted to start asking some questions. So especially when you face a patient face-to-face and they ask you, what are my chances of vision loss, especially when there is a posterior disease? Will I ever need optic canal decompression, and what is the visual prognosis? So the aim of our study was to look at the clinico-radiological features in CFD involving the orbit and look at the visual outcome in those undergoing optic canal decompression. So we had about 22 patients in the last 10 years, and we had a slight male predominance. Mean age was 20 years. And if you look at the second column, surprisingly, about 40 of 44 eyes, that is 90% of patients, actually had 6x6 or 6x9 vision. And four eyes had the other extreme. They had really poor vision, one with no PL, two with hand motions, and one with 6x60. And if you look at the third column, you see that optic canal involvement radiologically was seen in 50% of the cases. So although 50% had canal involvement radiologically, only four eyes had significant vision loss. That was about 9%. So some of the associated features we know are McCune-Albright syndrome, where you have precocious puberty, endocrinopathies, along with fibrous dysplasia. And this happens mostly in children, and this warrants a prompt referral to endocrinologists. In our cohort, observation was done in 10, bisphosphonates were administered in 5, canal decompression was done in 3 patients for 4 eyes with the poor vision. Prophylactic decompression was done in none, as is advised, and bone contouring for cosmesis was done in 6 patients. This was one of the patients with bilateral optic nerve atrophy who underwent endoscopic expanded 3D navigation guided canal decompression, and one of her eyes actually improved. So at a mean follow-up of over 2 years, we found that those with 6x6, 6x9 vision actually remained unchanged. With those with poor vision, the no PLI and one of the hand motions, or PL plus eye, remained unchanged. One of the eyes with hand motions actually improved to 1/60, which I wouldn't call significant. One eye with 6/60 actually improved to 6/36, and she actually reported significant subjective improvement. Now, so this is what we actually observed as far as vision was concerned. And this kind of gives us a starting point. Maybe 6/60 is the cutoff, which can be quite sensitive to actually say that there might be some improvement, although our cohort is quite small. Radiological progression or recurrence was seen in 4 patients, close to 20%. And this again fell across all groups. 1 patient who received bisphosphonates, 1 who had surgical decompression, and 2 who had bone contouring. So we're not really able to say if bisphosphonates actually prevent regression or if surgery causes, recurrence of disease. So Lee et al. Actually found that 88% who had radiological bony involvement had no optic neuropathy. This was about 73% in our eyes, which meant even though there was bone involvement, vision remained stable. And even in meta-analysis, they show that 95% who were observed and 75% who had surgery had long-term stable vision. But this still really doesn't answer our questions. What are the factors that predict optic neuropathy? We couldn't draw a conclusion, but we had 2 patients with growth hormone excess, one with inducible bone cyst. These are some of the reported factors that can cause progression of disease. I will skip this time due to want of time. So in conclusion, vision is not always affected in case of optic canal disease. Up to 80% can have stable vision even with the radiological involvement of your optic canal, and prophylactic decompression is not advised. Visual prognosis of those who present with poor vision can be guarded. Risk factors for predicting progression or nerve compression is unclear. But if you see a patient with poor vision, especially for future multicentric studies, maybe 6/60 could be a sensitive cutoff where we can closely look at to see if those patients, whether they improve or not. Like I said, we need larger studies to really address this issue to answer our patients' questions better. Thank you. These are my references.
Thank you, Dr. Deepthi. Actually, what I was thinking that what are the basic indications for go for surgery? Because you yourself told that optic canal disease does not mean that patient will lose the vision, number one. But what are the other specialists which you would like to involve during the surgery?
I would definitely involve my endoscopic surgeons, because I think endoscopic surgery would be a safer approach for these patients. But we know that if a patient presents to you and they have radiological involvement of the canal and poor vision, you tend to offer surgery. But you always caution them that visual improvement is guarded. That cutoff is really not clear in the scientific community. If you have 6/6, do you improve? If you have PL plus, do you improve or not? In our patients with hand movements and less, did not improve, but they didn't lose vision, which is another thing that you're always worried about when you go for optic nerve decompression. So, yeah.
What is your...
But the other thing we have noticed is sometimes we see, like in some of the pictures I showed, there is significant canal narrowing on the CT, but the vision is actually pretty good. So then we decide to observe.
I don't know. I think I can just. I think it's very challenging, no doubt about that. But probably it would be good to look at visual field.
Yes.
Very closely, and other parameters of visual function. Deepthi is not a very.
Yes, you're right.
Yeah.
So we actually did fields for some of the patients, but we didn't have for all 22. It was a smaller number, so I couldn't really analyze it because the numbers were small. But we do recommend do it for all patients.
I can just draw a line from the decompression challenges I face, and a lot of times visual acuity is 20/30. But when you look at the visual field, when you look at the color vision, and sometimes even the VEP, you tend to know how bad the disease is.
Yeah, that is right. Yeah. Actually, I think the indication for surgery could be that if we do serial things, that if it is, we think that it is progressing, then I think it is advisable for the patient to go for the surgery.
Yeah. And one of my patients...
Because basic thing is that if we cannot do better, at least we cannot do worse.
Correct. So like sir said, fields, color vision for sure. And one other thing I would look at is what this patient feels. Like one patient improved from 660 to 3/60, which is on Snellen's is just one line. But she really reported a subjective improvement and she was really happy. So always go by that also.
Oh.
Okay, thank you, Dr. Deepthi.
What procedure normally you do to visualize the optic canal?
So,
Radiological procedure?
CT scan.
Only
Just
CT scan,
because
or you just want to modify that?
contrast enhanced CT, just
No,
because it
anything
is
else?
smaller cuts to see the optic canal.
See, CT scan with 3D reconstruction
Okay,
should be better,
Yeah.
isn't it?
Yes, we ask for sagittal and 3D reconstruction in all patients. Thank
Okay.
you.
Thank you.